Neurophysiological balance in the chiari-1 malformation.
Thank you very much for introducing me. I will try to explain what neurophysiology can do to help clinicians and physiologists to deal with this disorder. Neurophysiology can be aimed at different levels and objectives based on the history and signs and symptoms. So there are specific tests depending on clinical data and correlation with neuroradiological findings. They may have predictive value or help to establish the right timing for surgery. They can also be related to intraoperative monitoring, thus contributing to minimize the timing of surgery. They can also optimize the stages of surgery and help to evaluate the reversibility of deficits, as in these patients, especially carrier 2 patients, there are complex syndromes that require to be monitored to obtain a balance in order to understand how data vary. This is the anatomical scenario shown by an MRI image. At a functional level, this area is especially critical and interesting, as different systems and structures are bundled here in this area and can be easily explored by means of functional methods. One example is SEPs, somatosensory evoked potentials, which can be used to study the spinal pathway. Motor evoked potentials are the descending motor pathway, and by the way, MEP have never been used in this issue. Brainstem auditory evoked potentials are used to evaluate brainstem functionality at the brainstem or auditory functions. Cranial reflexes such as blink reflex, jaw reflex, and more recently silent period, jaw silent period, are reflexes which explore certain circuits which are located in these structures. Some centers are very interesting in that they are involved in sleep, and polysomnography can be very useful in this respect because sleep disorders are, under certain circumstances, especially significant. Visual evoked potentials, moreover, can be used to evaluate the effects of indirect injury at an occipital level, and SEPs can also be used to evaluate spinal cord injury. Neurophysiologist tools are auditory EPs, somatosensory evoked potential, blink reflex, and polysomnography. These are the key methods which have been more extensively studied in the literature. Auditory evoked potentials explore 2 functional levels: peripheral function, for example, and in this respect they're very useful to evaluate auditory function and brainstem function. This is a recording as we do it in our practice. The peripheral wave reflects auditory reactions. The central ones reflect brainstem activity, and peripheral waves are used to assess cochlear receptor activity. BAEPs can be used to evaluate threshold auditory loss, also as it's not always useful to evaluate auditory loss in children. Somatosensory evoked potentials can be used in very young children to evaluate these points, and in toddlers they provide evoked responses along the entire segment, from peripheral to lumbar, thoracic, and cortical responses. By measuring conduction times, specific parameters can be obtained as to how these impulses are transferred to the cortex. There's a key aspect which I believe is the limiting factor to a more extensive use of this technique in pediatric patients. That is maturation. Either because of growth or because of somatic factors, there are alterations during pediatric in childhood, thus preventing these potentials from being applied to pediatric patients. Since no parameters are available for children, clinical application of these potentials is difficult in children. This is the latency of the N20 potential. This is the central conduction time, and as you see, N20 latency varies with age, just like TCT. This is the N9 to N20 conduction time. This is N20 latency as a ratio of stature. Here you see that in this range there's a decrease in latency, but in this other interval there's a novel increase in latency. If patients of this height or age are studied, if the potential is stable, this doesn't mean that the potential is actually stable. It means the opposite. It means that the patient is not growing because there's something that interferes with growth. On the other hand, children who are examined at this age, whose potentials change, have changed, altered potentials because they're growing. This is very important to know because each sensory pattern is related to a specific maturation pattern. Blink reflex is the most established method in clinical neurophysiology. It's very difficult to measure. Small electric shocks are applied to the trigeminal nerve. Responses are obtained which specifically modulate some oligo and polysynaptic pathways of the brain stem. There are monolateral and bilateral synaptic responses. This test is well tolerated, and there are different alteration patterns which can be classified by neurophysiologists and point to different dysfunction levels. This is a method that has proved especially significant in Arnold Chiari patients, especially Chiari 2 patients. In craniocephalic reflexes include jaw reflex or masseteric reflex. The trigeminal nerve is stimulated by beating on the jaw, and this is silent period testing, which has been used in Chiari patients, notably by Rome's Kruppko. Silent period testing has been used on all sorts of disorders in patients, but not in children. The last test is polysomnography, which combines a traditional recording with other recordings, such as electromyography, breathing tests, and ECGs. This is a recording that was made by us during synchronous sleep, and it yielded a full set of information ranging from the cortex to other areas. Polysomnography is useful for the reasons I will outline to you later on. What does neurophysiological literature, the literature in neurophysiology, say about these tests and Arnold-Chiari malformation? From 1983 to 2009, around 40 papers have been published in the literature. Topics were pre- and correlations with radiology, matching with clinics, comparison of methods, development and evolution, intraoperative role, and correlation with specific symptoms. Suppose that one wants to monitor auditory function, a protocol involving auditory evoked potentials can be used. This morning, Dr. Riva mentioned usage of these potentials, and sometimes polysomnography is used. There are 2 or 3 papers that were published between 2006 and 2009 and concerning polysomnography. The most frequently used method is ABR. Nearly all authors performed ABR alone or in combination with blink reflex, PEV, and polysomnography. Results were diverse because there were differences in case series, patients' age, and the aims of studies. But basically, I would say that a distinction is made in the literature between early childhood and childhood. Among other things, nearly all data refer to Chiari 2 patients. Very few data refer to Chiari 1 patients. Information and evidence on early childhood says that BAEPs are highly sensitive, certainly more so than SEPs. But BAEPs do not correlate with IBS, infantile brain syndrome, whereas SEP does correlate with infantile brain syndrome. EPs seem to anticipate symptom development. This is the result of the first study. The subsequent study confirmed those data, and a third study was on surgery timing. A recent paper was published on 67 subjects, and it was about a comparison between BAEPs and blink reflex. Blink reflex is supposed to help to identify asymptomatic patients better than with symptomatic patients. Then there are papers concerning older children. Here, One paper provided an early proposal for auditory assessment. In 2004, a review was published with a classification of Chiari 2 and Chiari 1 outcomes. This review also highlighted the potential role of polysomnography as related to cognitive deficits. This is a slide showing BAEP contribution in early childhood. These are peripheral and central assessments combined together. This slide shows how the most significant BAEP alterations are more interesting to neurophysiologists. Interestingly, in early childhood, a deterioration or maturation delay doesn't always point to a worsening, because both BAEPs and blink reflex, after an early worsening stage, can resume their normal maturation curve. So if at this level one can adopt a wait-and-see attitude and wait until the potentials recover. If they don't recover, that's an alarming sign. These are slides showing BAEPs and VEPs. This is a picture from the literature, and this is one case report. This is a Chiari 2 child patient. He was referred to us with not much accompanying information. In this child, we found a severe important hypoacusia. We also found upper limb problems, and lower limb SEP highlighted a cervical disorder. So basically, in this child, we found 3 disorder levels: unilateral hypoacusia, one dysfunction showing an early dysfunction of the gray matter in cervical cord. Lower limb SEP in pre-surgery is not supported by much evidence. In Europe, the latest publication by French authors was not based on this method, which can be used to study an increase in central conduction time and how it changes during surgery. BAEP has been extensively used, even though the previous speaker mentioned SEPs rather than BAEP. This is an intraoperative SEP finding. Here you can see that BAEPs and SEPs are altered at certain times, and if intraoperative setting is changed, the spike is reversed. So as a conclusion, the literature provides BAEP consolidated and established information and evidence. So we have the most consolidated data on BAEPs. As for blink reflex and SEPs, data is interesting but still requires confirmation. Evidence on polysomnography concerning sleep-wake disorders still needs to be verified. The most interesting information is, in my opinion, related to BAEP rather than SEP rather than BAEP. Thank you, Mr. Scaioli. Your presentation was very interesting, but unfortunately there isn't much time for questions. Moreover, your presentation was so technical and so detailed that perhaps there won't be many people who will dare ask questions. Microphone, please. We will discuss tethering. I would like to know what meaning SEPs have in tethering syndrome. because it's very difficult to correlate with clinical data. So how can these potentials help us to figure out whether a tethering syndrome is becoming clinical, is getting worse? There are two aspects involved here. At the moment, we use three potentials: lower limb SEPs, upper limb SEPs, and BAEPs. That's because we have noticed that if BAEP deteriorates, it may deteriorate before SEP. So we noticed this on certain patients, so we decided to take this approach. Our alternative approach is a urodynamic type of approach, but we use all three methods for that. I think we should try and explore blink reflex as well. I use SEPs intraoperatively and transcortical MEPs. So I do agree with you that SEPs are the most established method, but we also use transcortical MEPs. Do you agree with this decision? Of course, we use them on adult patients. As for adults, Rome's evidence shows that the effectiveness of coordinated MEP-SEP monitoring increases, so the two combined methods should be used. I think that you use a lead pacing, and a lead pacing yields very good, reproducible, and highly reliable results, just like SEP.